share. I'm going to preempt you, Mr. Tate. I am taping this lecture, and I'll put it up in the lecture for the day. But let me present this to you guys too.
Thank you. Yeah.
You're very welcome, sir. Okay. So I'll probably, by the way, talk about 5 o'clock and then let you guys take a break and release homework and all that kind of stuff, because it'll just get too much if I kind of go through the whole 2 hours that's left talking to you. All right, this is kinesiology. I am hoping, by the way, don't feel bad. Like, I'm hoping this is review, but some of it won't be. Some of it you'll be like, I missed that concept or I didn't get it. So this is also a chance to clean things up as we go through. So this chapter, I actually really like this chapter. We're going to discuss what kinesiology is, and we're going to discuss a lot of the bones and the bony landmarks. Remember the bumps in the bones where muscles like to attach? And then we will eventually get into what do those muscles do and what actions they create and all that kind of stuff. So kinesiology, though, is the study of movement. How do you move? And to me, it's also structural anatomy, because how I move is also how I stand. And I don't mean that I stay in this position when I move, but my point is, it's how, even though there's no motion occurring right now in my body, basically, I'm still using movement muscles to keep me in one place. So movement also kind of helps you understand, like, why is that pelvis tilted or not? Why is all these things? So it's all really the same stuff in my mind. And don't forget that really what we study here is really that muscles shorten and they pull on bones, and that changes their relative position. My bicep shortens and it literally pulls on this bone and changes the position of my arm to my forearm to my arm. And that's just what happens. All right. Let's talk about bones a little bit. Yeah, yes, Mr. Blygen, please.
I had a quick question, and I don't want to get too off task.
No.
Are there any muscles that don't attach to bone in the body?
Yeah, there actually are, sir. So there's a lot, actually, and don't ask me to name them because I don't study them, but there are lots. So the muscles, we in massage therapy, we care about kinesiology, and we care about structural anatomy. And so if it doesn't attach to a bone in general, not always, but in general, we don't care. But you've got loads of muscles that don't attach to a bone. Let me show you one right here. So I'm not puckering up to kiss you. That is a sphincter muscle, and it's not attached to any bone. It's in my skin. My eyelids are a great example, but you've got loads of like sphincter muscles inside your body. You've got all sorts of muscles that are woven into tissue that are not, but they're not really movement muscles as much. They're usually to open and close openings in your body to, well, there's actually muscle around all of your arteries and all of your veins that open and close the size of those tubes. So yeah, you've got muscle that's actually woven into your skin and doesn't go to a bone. And you've got muscle around many, many internal organs. So yes, you do. Yeah. And a lot of like your pelvic floor too, which we don't really think about, but a lot of your pelvic floor is made up of muscle. Yeah, it's not really attaching to bone, not all of it. So I hope that answered your question, but yes, sir, not all muscle attaches to bone.
I was just curious. Yes, and yeah. It does make sense.
Yeah, cool. The obvious ones, by the way, I don't mean to run it in the ground, but the obvious ones are facial expression muscles. There's a whole bunch that are just in my cheeks to make me do stuff with my eyebrows and face and stuff. Cool. Okay, so bones. Bones have bony markings on them or landmarks, and that's actually how we find our way around the body. I know this is obvious to you. But there are no bumps on your body, essentially, that are there without a reason unless you ran into something. So the bumps on your bones are always attachment sites for tendons or ligaments. And that's the purpose of them. The purpose is that we can find a bony landmark and then figure out where we are by what's attached to it. So, we're going to let that go. Let's talk about though. Sorry. And we've got lots of names for bumps on your body, and you don't have to separate them. But a protuberance is something protruding. It's a bump on your body. And really, that's the same thing as like an epicondyle, for example. An epicondyle is a bump on my body too, but epicondyles tend to be found at the end of bones. So your greater trochanter and your lesser trochanter are bumps. Tubercles are bumps. Tuberosities are bumps. Spines are bumps. Remember, spines aren't just our spine here. Remember, we've got the anterior superior iliac spine. It just means something poking out. We've got ridges and ramuses. Ramuses aren't really bumps. Ramuses are kind of the arms of the pelvis and such. But just that we've got all these bumps and processes, things like that. And then we've got holes and indentations. Remember, a foramen is a hole, right? We've got the obturator foramen in your hip, where your obturator internus and externus originate. You've got a foramen magnum actually in the bottom of your head. You'll never see it, but it's where your spinal cord comes out from your skull to go down your back. And we've got all sorts of those. And then we've got fossas and grooves and notches, and they mentioned sinuses here. We won't get into those, but those are open cavities in your head. Okay. So I don't know if you remember this, but way back we talked about the appendicular and axial skeletal system. Yeah. Who can tell me what the axial skeletal system consists of? The axial skeletal system. Anybody?
Is the wait a minute.
Yeah, hold on one second. Somebody raised their hand. Miss Mares, please take it away.
The axial skeleton is the skull, the vertebral column, sternum, and the ribs.
That's beautiful. Thank you. Yeah, it's your skull, your spine, your sacrum, which is kind of your spine, and ribs, right? And that area articulates, but it's the central area that, by the way, think about it, it houses the things that you think of as you. Your brain and your heart and your lungs, all the machinery that you need to kind of keep yourself alive. And then the appendicular skeletal system is your appendages. And that is where they hook onto your body. And that is where we see the highest levels of stress in the body. We usually see it either right down the axial skeleton system, right down the spine, or where the arms and legs attach to that area. Who here can tell me the actual joints that attach your appendicular skeletal system to your axial skeletal system? You might just want to do the arms or the legs. Yes, Miss Mejia, please. Give me one of these.
The sternoclavicular joint is the one for the upper appendicular skeleton.
Yes, excellent. And thank you. Perfect. And Miss Estes, can you give me the bottom one?
The sacroiliac joint.
That's beautiful. By the way, they both just answered the entire question. There is no other true joint. True joint by our definition, by the way, by the people that make these books and stuff, that attach your arms and legs to your body. So you got the sacroiliac joint, which is where your sacrum meets your hips. And you've got the sternoclavicular joint. Now, is the sternoclavicular joint housing all the power that keeps my arm on my body? Absolutely not. It would get torn off in a second. It's actually my trapezius back here and the rhomboids and everything sewing it onto my back with a fake joint that I call the scapulothoracic joint, where the scapula moves around your thorax. But that's not an actual joint. It's just, I call it that because it moves, and we got to talk about it. So excellent. Good. Cool. Sounds like we got it. Oh, and by the way, not a bad approach to massage. Rub the whole spine and really release shoulders and hips, because then you've hit a lot of these high tension areas. Yeah, in fact, I'd say release the spine, release shoulders and hips, rub the feet, and move on your way. Yeah. I mean, if you wanted a quick 50-minute massage. Okay. We won't go into all of the bones, but we have your collarbone, which is called your clavicle, right? Scapula. Upper arm bone, humerus. And then remember, we've got a bone, 2 bones in my forearm, right? Which one goes to my thumb?
Radius.
Radius, thank you. Which one goes to my pinky?
Ulna.
Ulna, that's right. And they can switch positions, don't forget that. Like they are parallel in this picture, they are not. This one is actually starting down here and going over there. They're actually twisting around each other, switching sides. And that's how I supinate and pronate. Cool. And then I've got 8 wrist bones. What are those 8 wrist bones called as a group?
Carpal.
Carpal, yes, and there's 8 of them. And then the bones that come up from the carpal are the
Metacarpals.
metacarpals. And then I've got 14 little,
Phalanges.
Branches.
yeah. So, Mr. Placencia,
Yes.
which phalange is this one right here?
The first one. I don't know.
So, it's okay, they're totally okay. Anybody know, by the way, before I explain?
Findex.
What?
Findex.
Well, it's your index finger,
Yeah, index.
but how do we name,
Oh.
if there's 14 phalanges, there's 2 in my thumb, 3 in this finger, 3 in this finger, 3 in this finger, 3 in this finger. How do I talk about this phalange right here? Anybody?
Distal.
Please keep going, ma'am. She's right, it's my distal phalange because there's a proximal phalange and there's a middle phalange. Distal, proximal, middle. Excellent. But this is distal too, and this is distal too, this is distal too, this is distal. What is this one? Distal?
I think it's number 4, isn't it? No, it's number 2.
Yeah, but you have the right idea. So this is 1, everybody, just so you know. 2, 3, 4, 5. So this is distal phalange number 5, proximal phalange number 5, middle phalange number 5. Yeah? We got that? Does that make sense? So Miss Lovitz, you just look confused for a second, so I like to call on you. You got great facial expressions. What is this phalange here?
Distal 1.
Distal phalange number 1. Excellent. Thank you, thank you, thank you. Ms. Vincent, what phalange is this here?
Proximal number 5.
Yes! Thank you. Awesome. Miss Mejia, can you show me distal phalange number 3? That one. Yes, I was worried you're going to get yourself in trouble there for a second. Yes. Awesome. Mr. Placencia,
Yes.
can you show me middle phalange number 1?
I'm sorry, I wasn't paying attention for a bit.
That's okay, sir. Can you show me middle phalange number 1? Or do you want me to just skip you? I'm okay skipping you once in a while.
We can skip me.
You got it. Mr. Brown, can you show me middle phalange number 1? Bad. That's number 2. I need number 1. That's number 5. Pinky's 5.
The thumb counts as a phalange.
I'm sorry, you're echoing, sir. What'd you say?
The thumb counts as a phalange?
The thumb counts as number 1, and it's got 2 phalanges in it.
So it's this one.
Nope. It was a very.
Hold on.
it was a
The
very-
audio cut off just a second ago. Can you say that one more time, please?
I said no. It was a very mean question. There is no middle phalange number 1 because you've only got 2 phalanges. So we call this distal and proximal. There is no middle. There is all these other ones. But you're on the right track, sir. Yeah. Cool. So there is no middle phalange number 1, everybody. It's a trick question. There's only 2 bones here, so one's distal, one's proximal. In my fingers, there's a proximal, middle, and distal. That's how we do that. Cool? All right. Good. Awesome, awesome. Moving right along. You also want to start, and by the way, I've already seen you guys do this, but we want to start using the proper terms for joints, right? So this is my, can somebody tell me what my shoulder joint is called here between my arm and my scapula? Yeah, I saw somebody mouth it.
Glenohumeral.
Glenohumeral is correct. Yeah, it is the glenoid fossa, but it's called glenohumeral. And the humerus inserts into the glenoid fossa of the scapula. I really wish it was called scapulohumeral or something, but it's not. Glenohumeral, you are right. It's the glenoid fossa, but it's called glenohumeral joint. And by the way, that's helpful, everybody, because we all know now that shoulders aren't just this. They're my scapulothoracic joint, too. And so sometimes we're really talking about different things, right? And what is the joint between my elbow and my forearm called? This one's a little trickier in some ways. Depends how you look at it. Yes, Miss Mejian, thank you. What?
I get them confused. I think it's the humeral ulnar joint, or it's the radial ulnar joint.
Stop.
Oh, okay.
Go back, because you did it right, so I want it stuck in your head right. So don't say you're confused this time. Answer the first part like you know it.
Radial ulnar joint. No. Humeral ulnar joint.
Yeah, humeral ulnar joint. By the way, we realize that this thing is interacting with the radius too, but the strength comes from the humerus and the ulna. That's what makes this beautiful joint here. My radius is actually the thing that kind of flips over the top of it. And that is, by the way, when it flips over, that is a radial ulnar joint. The radius going over the ulna. And there's a distal and a proximal radial ulnar joint. But yes. And then it's your radius down here that tends to interact with your carpal bones. Right? And we all know this because it kind of looks weird, but essentially, essentially it's the way it works. So your humerus interacts with this big, this is the thumb. The humerus interacts with this big ulna here, and it gets small as it goes up here. The radius is small here, but gets big up here and interacts with your carpals. Your body's kind of got a dual thing there, where the bones get different sizes as they go. And this is a joint, this is the radial, do not listen to what I just said. This is the humeral ulnar joint, this is the radial carpal joint, and these places between the radius and the ulna that allow me to flip my hand over are distal and proximal radial ulnar joints, where the bones actually flip over each other. Cool. Moving right along. We are not going to get into that. It's not that important. We know all this stuff. There will be some review in your book of all the lovely things on the scapula. Do you guys remember that like a lot of our rotator cuff muscles actually steal names from the scapula? Right? So the subscapular fossa, the fossa underneath the scapula, the subscapular fossa has what muscle in it? What rotator cuff muscle?
Would it be the subscapularis?
Yes, ma'am, it would be all day long, subscapularis. And the supraspinous fossa, the fossa above the indentation above the spine of the scapula, would have what muscle in it? That's right, Miss Lobitz. You can read lips, and she said supraspinatus. Excellent. Good. Just want to kind of remind you guys of all that. And remember, some of the stuff that we really want to care about as massage therapists is like all the muscles that attach to the medial border of the scapula, which Mr. Placencia is going to tell us right now to redeem himself from the debacle that we had with the phalanges. I didn't want to bring it up again. It was very embarrassing, sir. But what are the muscles that kind of, as you kind of go up the border from inferior to superior, what are the muscles that we go through on the scapula?
On the scapula, we have the rhomboids, major and minor. We have the anterior, the serratus anterior.
That's in front, yes, but to the medial border still, you're absolutely right. And if you go up a little bit higher, there's one right above rhomboids major, kind of attached to the superior angle, the scapula, and then inserts into...
Levator scapula.
Thank you, sir. That was all four. Good. And I should have been more clear. He knew what I was asking, but I meant the medial border. There are muscles that are kind of attached to the lateral border as well, which is like the teres major, right? And we see teres minor and infraspinatus come out over there too. Cool. Thank you. Love it. Oh, great pictures. Okay. We just talked about all this. Oh, just a little thing to remind you too. Don't forget that the end of your elbow, which is actually your ulna, but this bump here that you can all feel, that is your olecranon process. It is called your olecranon process. It's a common use of the word. People talk about it. Massage therapists don't usually call it an elbow. They call it olecranon process. But it's part of the ulna. It's right back there. That's your olecranon process. Cool. Moving right along. This is the radius. Beautiful. This is a great picture, by the way. You can see how the radius actually gets wider as it goes down to meet the carpals. And how it's tiny and round at the top to roll over the ulna. It really is like that, to roll over the ulna. There is some white stuff in between the ulna and the radius. This is true of your entire body, by the way. But there is some stuff between the ulna and the radius called interosseous membrane. Can somebody tell me what interosseous means? Just think.
So, inter is in between. Os, I want to say bone.
Yes! Thank you, sir.
And membrane.
Yeah, sir, that's beautiful. It is the membrane found between the bone. He's exactly right. Inter means between, like interstate transport. Osseous or osteoarthritis, right? Bone arthritis. Anyway, osseous membrane means a membrane between the bones. I'm only making kind of a big deal of it here, everybody, because that fascia can get tight too, and I don't want you to really think that there's any empty spots in the body. There essentially aren't. I know I've talked about hiatuses where nerves and stuff go through there, but there's no place where you open up the body and you're like looking through holes, you know, and you see your lab partner over there in the cadaver lab. It doesn't happen. Everything's filled in because it makes it structurally stronger. If you think about it, it really is amazing that I can hit my hands together and nothing really gets hurt, and all that shock is being taken up because there's fascia woven everywhere. Yeah, cool. Okay, we talked about all that. I love it. So this is the name of the carpal bones, and I haven't discussed it with you yet because we do forearms and hands very last in the course. But it's good to start familiarizing yourself with them. I want to be very honest with you. I don't use them in my daily practice. I personally feel that if you can recognize them, that would be good enough. Yeah? And let me see if they have a picture here. I'll tell you about. Yeah, let's see. Hold on. Yes, that's right. Okay. So they go from, starting the way, the way they listed them is starting from my thumb over my pinky, back from my, I think, yes, hold on, I might be telling you wrong now. Yes, that's right, good. Hammy, good, okay, yep. Please tell me. Okay, yes. So like reading a book, they're starting, there's two rows, they're starting from my thumb over to my thumb again over to my pinky. So scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate. How the heck do you remember that? I don't usually. I've told this before, I'm not trying to be inappropriate, but a lot of people remember it by the acronym Some lovers try positions that they can't handle. So that is just the most common. We taught high school, we had something else because we couldn't tell them that. But I think you guys can handle it. So scaphoid, some, lunate, lovers, triquetrum, try, so on and so forth. Scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. So you might want to I don't think you should memorize them, but become familiar with them. What you really want with some of these lesser known things that you don't have to know every little thing about is that you just want that if somebody said scaphoid, you'd be like, that's not scapula. That's one of those bones in your wrist, right? That's a carpal. Does that make sense? Cool. All right. Well, they're great names. Yes, Mr. Blygen.
Are they the same bone names in the tarsals?
No, not at all. So,
Okay, you don't have to go into it. I just was curious.
No, it's a really good question, but I want to say something about it really quick, though, because there are some similarities. Your phalanges are your phalanges, whether they're your fingers or your toes. But when it comes to carpals and metacarpals, you've got 8 carpals and 5 metacarpals in your hands. In your ankles, you've got only 5 tarsals and 5 metatarsals. So tarsals and metatarsals and phalanges. In your hands, you've got carpals, metacarpals, and phalanges. So I hope that helped. But that is one big difference is you've got 8 carpals and only 5 tarsals. The tarsals are much bigger, though. The rest, there's some real similarities. Okay. This is a great picture of the carpal tunnel, but we're not going to get into that right now. We'll be doing that later. Okay. Then we also are starting to learn the bones of the lower body. And we haven't really gotten that far into it, right? We've been looking at the pelvic bones, right? And there's actually 3 bones that make up your pelvis, correct? On each side. Yeah. Can somebody tell me, somebody who I haven't heard from, tell me what the 3 bones are that make up your pelvis? Or I can just call on somebody. Anybody? Somebody new? Please? No? Have to call on you? Okay. Miss Allure, what are the 3 bones that make up the pelvis?
The ilium, ischium, and the pubis.
That was perfect. That was exactly right. Thought you were going to have a hard time with it. Cool, that's awesome. Yes, the ilium, ischium, pubis. Then it goes down into our thigh bone, the largest bone in the body, one of the hardest ones to break. You only see this broken in car accidents, really bad ones too. Is the femur. It's also, by the way, lots of your bones do this, but long bones, and this one's the biggest long bone, is where you make some really cool stuff inside that bone. What was that? Casserole? Punch. Salad? What do we make inside our long bones? I feel like it's something important.
Bone marrow?
Bone marrow, well, yes, but what does the bone marrow produce, sir?
White blood cells?
White blood cells, and were you going to say something, Mr. Riedel? Or is that what you're going to say?
I was going to say red blood cells.
You're both correct, thank you. Red and white blood cells are made, thank you very much, by the way. Red and white blood cells are both made inside your bones. It's just a very cool thing. Yeah. Okay, cool, and then that femur goes down onto your thickest bone in your leg, which is your tibia, which is medial, because laterally you've got a little fibula, which is much tinier, and that's lateral to your legs. And then we go down into your 5 tarsals, that go to your 5 metatarsals and your 14 phalanges again. And by the way, everybody, we're going to do legs. I mean, that's where we're headed, so don't sweat about that too much. And we tried to chop your test off for tomorrow, so it didn't include stuff that you don't have yet. Cool. Here we go. It's an excellent picture. I do think you should all remember that the tibia is medial and the fibula is lateral. You should remember the thick tibia is medial and the fibula is tiny and slender and lateral. Yes. And I don't know if this helps. I'm not trying to be rude or anything, but the way I remember this is I used to have a friend, Tibby, and she was kind of heavy set. And so I just used it to associate with the bone because it's the thicker of the bone. And so I don't know if that helps you. Tibby. Remember my friend Tibby? Yes. Beautiful picture of the pelvic bone, getting pretty complex here, with the acetabulum where your femur inserts into. And remember, this is where we learned terms like ramus, which really meant the arms of the pubic bone has a superior ramus and inferior ramus, and it meets with the ramus of the ischium, and together they start to form your hips. It's kind of cool. Great picture here. Please just soak this in for a second. This is the side view of, yes, Miss Mejia, please.
I know you don't like me to say sorry, but I'm sorry for interrupting. So if someone were to break their pelvis, do you think they would break a ramus because it's like one of the smaller parts?
Yes, I do. I don't know statistically like how correct I am, but yes, I do. I really do. Obviously, it depends on how they hit and all that kind of stuff, but I would think that you'd be very common to have a break between the inferior arm of the pubis and the arm of the ramus. Right down there where the blue and green meet here and form the obturator foramen. Yeah. Yeah. And hip breaks are pretty serious. Usually it's a sign of, some bone degeneration too. But yeah.
Thank you.
Thank you. Not going to get into that. We talked about the hip joint. By the way, I heard some of you call it the coxal joint in your homework. I appreciated that. That's what many people call it. It is also the acetabulo-femoral joint. I don't know why. It's a very long word, but I actually kind of like it. It just sounds cool. Anyway, it's the tab where your ass inserts. Remember, acetabular joint. That's how I remember it. It's always something inappropriate. Got to kill somebody or say something inappropriate. Okay. We talked about pelvic tilts. Remember, we measure them from the top. I think you've all got this now, which really makes me happy. But when my front of my pelvis tilts forward, and I heard a lot of people say this in the homework, and it made me so happy. They said this would create an anterior tilt, which would make their bottom stick out. And that let me know that I was like, oh my God, they're really getting it. Like the hip tips, the hips are tilting forward, but that makes the bottom kick back. A posterior tilt actually tucks your bottom underneath. Too much. Get your spine really straight. So, and then we also learned that there can be lateral tilts or lateral elevations, depending on how you want to talk about that. Oh, they call it right tilt and left tilt. Okay. I've actually honestly never heard that, but I'm sure it's true. We'll take it. So right tilt, right elevation, lateral tilt, all those things mean the same thing. It's one side coming up. And by the way, in general, that's a more serious problem. The body's got things to balance out forward and back tilts. It gets kind of tricky when you start kicking the hips out one direction or the other. We talked about the importance of the sacroiliac joint, right? Miss Estes explained to us that that is where the lower limbs attach to the axial skeletal system. And even to add even a little bit more emphasis to that, that is also the joint that takes all of the weight. I lift up this pen, and it's not too heavy, I admit, but the weight of this has to get distributed through my sacroiliac joint. It doesn't just magically disappear in my arms. So anything I do with my upper body has to get distributed through my sacroiliac joint. And think about the times that you stand on one leg, and then it's going through all one side of the sacroiliac joint. So it really is a high tension area, which is why I think you get that kind of deep ache back there. It feels like it's in your sacrum, and it's, I can see some of you like, yeah, I've got it right now. Yes. We have mentioned this many times that the sits bone is another term for the ischium. Remember, your tuchium is where your ischium is, and you sit on it. That's why they call it the sits bone, literally, because you sit on it. Do not confuse that with the sits muscles, which are rotator cuff muscles that some people like to call the sits muscles, because that's how they remember them. Supraspinatus, infraspinatus, teres minor, and subscapularis. And the pubic symphysis, which is where the two pubic bones come together. Yep. And where if you are birthing a child, hopefully relaxin is kicked in, that hormone is kicked in, soften this up to let your hips spread a little bit to make birthing easier. That's what attaches the bones in front. Not going to get into all that yet. This picture's not excellent, but can you kind of see the sloping of the femurs kind of coming down this way? Yeah, again, kind of makes my point about the IT band and why I work it down distally usually instead of proximally. I work it proximally but lightly. I work it hard distally. And the condyles of the knee, we haven't actually studied knees yet, but we're getting there. They're kind of cool. So, your hip joint is your acetabular-femoral joint. Your knee is called your tibiofemoral joint. It's where your tibia and your femur meet. That makes sense. Your ankle joint, never mind. Just remember that your patella-femoral joint, by the way, this is not something many massage therapists talk about, because it's true your patella is this kneecap that articulates with it, but we don't really consider that to be the knee joint. We consider the knee joint to be the tibia and femur, tibiofemoral joint, and the patella actually just helps hold that all together. But it does interact. It's bone interacting, which is why they gave it a name. We will later study a little bit about the ligaments that hold your knees together. There are some really cool ligaments in there, so just for a preview of coming attractions, you have an anterior and a posterior cruciate ligament. Those are inside your knee and they make a little cross like this, and that's why they're called cruciate. They mean the cross-like ligaments, and those are inside your knee. And then you've got collateral ligaments, which mean you've got them on both sides, and those help hold your knee together. And we can see the patellar ligament there, holding the patella to the tibia. What four muscles insert into the patella? Thank you, Miss Mejia. Anybody else? You are correct, by the way, ma'am. What four muscles insert into the patella?
The quadriceps.
Thank you, ma'am. What are the names of those?
Couldn't tell you.
Well,
I'm just kidding. I'm kidding.
okay. I was like, we can work through it.
Rectus femoris. Sorry, I was getting the mail and I walked away from my book.
You don't need your book.
Vastus medialis.
Mm-hmm.
Vastus intermedialis.
Intermedius, sure.
Yes. I always mess up the endings on those two.
I probably do.
And what's the fourth one?
Well, if there's a medialis, shouldn't there be a...
Lateralis. Thank you.
Vastus lateralis. So, rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. Cool. Thank you, ma'am. Good job. All right. Tibia, the fibula. Hey, another point to make here, too. It's very hard to tell from this picture, but the bumps on your ankle, you all have a medial and lateral bump on each of your ankle. Those are bumps on the tibia and the fibula at the bottom here. So your medial malleolus is a bump on your tibia, and your lateral malleolus is a bump on your fibula, and your ankle actually kind of fits up in this space between the two. They actually sit down on a bone called the talus that we haven't gotten to yet, but it's this bone that holds the whole thing. It's called the talus. We'll see if they show it here. But you should know about your malleoluses. Here it is. Talocrural joint. I hate this name, but that is the crural region, and this is where the tibia attaches to the talus. Let's see if they've got a... There's a picture of the talus, but we're looking down on it. The tibia actually sits right on top of that. And so they call it the talocrural joint, which I think is a cruel name. Should be called the talotibial joint. But anyway, there you go. I don't think there will be a lot on your test about this stuff because we haven't gotten to it yet. I'm not going to say a lot about feet yet, but I do want to point out that there are arches. There's 2 to 3 arches depending on how you count them. Your feet have an arch like this, boom, that lets them shock absorb. But they're also rolled on the inside, so they also have an arch like this, if that makes sense. So the whole thing is kind of like your suction cups made out of rubber. It's meant to push out every time. And if you look at the size of the feet bones, you could crack them with your fingers. So how come, don't do that, Miss Mia, don't just, yeah. But we can't. They're quite sturdy. I'm able to jump around. I think of all the stupid stuff you did, you know. Maybe you were at a rave this weekend and you're jumping off boulders and doing who knows what, yeah? No, weren't doing that, okay, good. Anyway, my point is they don't break it. It's one of the miracles of the body, but it's a structural miracle. The whole idea is the flexibility of the foot is actually what saves it. This is part of the problem we actually see, and one of the things that massage does for people is people tend to lose flexibility. And I don't just mean the ability to touch their toes. I meant elasticity. Elasticity is the thing where I bounce back, and if feet kind of lose that elasticity, then they're more prone to break and stuff. So feet are very strong because, not so much because of the bones, but all the fascia that holds all this together so that they can start springing back step after step. And plantar fasciitis is essentially an overuse injury. When somebody has got so much, they've been stepping so much, or they have so much weight, usually both, whatever, it's a lot of things. But what happens is the muscles get tired, the ligaments start wearing out, and once the ligaments start wearing out, you get problems in here, and your body creates swelling actually, hopefully to get you off your feet. The problem is getting people off their feet. Like runners will tell you things like, well, I cut back on running. I'm like, oh really, that's good, because you kind of need to cut back. And they're like, I was doing 7 days a week, but now I'm taking a day off. I'm like, that's not going to cut it. But it's really hard when you're addicted to something, like that. That's healthy, basically. But anyway, that's what it usually requires, is quite a bit of rest. Yes, Miss Sarno, please.
Can the bottom or the of the foot, like when we walk or like they get shot like here, and they can put the small bone on that, like a.
It's okay. I just don't understand, but that doesn't mean you don't stop trying. So when they can get a small hole.
No, they pushing when they get shot, like on the.
Oh, when the muscles get short under there?
Yeah, under there, and they put the small egg bone on here, and they put against each other in like.
So are you saying the tension there causes problems in the bones in there?
Yeah.
Yeah, I believe that. By the way, guys, you can get tension in your foot that actually kind of pulls your foot out of alignment a little bit, because you want this nice arch there, but if it gets really tight, the bones, yeah, they don't line up so nice. They start to do this.
Yeah, they start put on other, and it caught like a hurt inside the leg or no?
I would think it would cause hurt everywhere. I don't know if I fully understand you, but it would cause hurt in your foot, could cause hurt in your leg, could cause hurt in your back. It could cause hurt in your neck. I'm not exaggerating.
Up to the hip also.
And what?
Go inside the hip also?
Yeah, definitely.
Because they just pull and they start to like in the back, the calf area, hamstring, and just on the front of the leg.
Yeah, it could be all that stuff. I know, well, only a handful, but a handful of really good massage therapists, when they work on people, they start at the feet. And they consider themselves to be structural therapists, and they're like, well, why would I not fix the foundation first? They work their way up the body every time, which makes a lot of sense. I don't do that. As crazy as I'm about feet, I don't, but it makes a lot of sense to me. You hear all those sayings: if your feet aren't happy, you're not happy. All that kind of stuff. Feet will mess up everything. Yeah. So I don't know if I answered your question, Ms. Sarno, but I agree it could cause lots of problems. Yes, Ms. Mejia.
So you know how like you're talking about the arches. If someone doesn't have like a very good arch in their foot, like myself. Someone, or I think I was reading something that it's a weakness in some of the muscles on the bottom. I think it's the plantar surface of the foot. Do you think that's the case, or do you think it's an actual like bone thing that the bones weren't formed correctly?
When what happens now?
For like someone who has like a low arch or like a flat arch, do you think that's a bone problem or like a weak muscle problem?
I don't know. This is a really fascinating thing. So here, we're kind of in this area of nature versus nurture. You've heard of that? Like how much of you is you because you were raised in your family, and how much of you, if I took you out of that family but you still had all their genes, obviously you would, you know, how similar would you be to how you are right now? And they call this nature versus nurture. And they even wonder it with postural stuff. Like, okay, you had slightly flat feet, but did you have a lifestyle growing up where you didn't get to develop foot arches, right? Because you didn't walk around barefoot long enough. Some of the things that are not good for feet, believe it or not, is wearing shoes too often. So because walking around barefoot actually causes you to grip the ground and actually work your arch support muscles and things like that. So I don't know the answer. I would just tell you, and I would suspect in a lot of people it's both.
Okay.
But you're right. I mean, some people are born with less arch than others. I just wonder how much of it gets aggravated by certain things or lifestyle choices, you know. And then that small flat-footedness became a bigger deal. And they didn't develop the strength, like you said, the strength under there to kind of build their arches up and such. Yeah.
So it could be either, is what you're saying.
Yeah, and I know it's a cop-out, but it could be both. That would be very likely, right? And they find this in genetics, everybody, right? Some of us have propensity towards something, but it still has to be triggered environmentally. Like you might have, like cancer might run in your family, but they find that there are lifestyle things you have to do to kind of set that off, right? You can still outride that thing. So I would think it'd be some combination. And I have no idea the amount. It probably varies from individual to individual. Yeah. Cool. Hang in there. We'll break in here really soon. We're not getting into all your metatarsals and your phalanges. I hope not, at least. We have not done skull yet, so I won't get into any of this yet, but we will. We will do skull. Some of the bones are actually quite obvious, and some of them you probably already know. On the back of your head, you have your occipital bone. And I would guess, I'm guessing, but I would guess this is the one that most massage therapists know because we care about rubbing the occipital region, right? Because there are 8, what are they called? 8, what back there? Take up about this much space, right here.
Suboccipitals.
Suboccipitals, thank you, sir. There are 8 suboccipitals there that attach my occipital bone to C1 and C2. And the bone here in front is your front bone, and then on the sides of your head are your parietal bones. And we will learn the rest when we get there. Yeah, it's good. Frontal, occipital, parietal. We also learned a little bit about a really cool bone that runs through my entire head called the sphenoid, but we'll get to that later. And remember, the bone I'm obsessed with is actually a little bit lower down here, and this is the temporal bone. And I'm obsessed with it because it has lots of features and lots of stuff attaching to it that creates lots of problems. For one thing, there's a bump back here called the what process? Anybody? Thank you, Mr. Marchant. I feel like you yelled it extra loud so I could hear it. Mastoid. Yes. Mastoid process. Mr. Blygen, what muscles attach to the mastoid process?
Hold on, the thing. Levator scapula? Or one of the erector spinae. So okay, then I'm wrong then. I don't know.
Well, one of the erector spinae.
SCM. SCM. Sternocleidomastoid.
Sternocleidomastoid. Excellent. It's got a name in there. Cool. Good. I love that one. Sternocleidomastoid. Give me another one back. One of the spinal erectors.
Spinalis. No. So the iliocostalis goes that way, then I want to say the longissimus.
Yeah, longissimus. It's got to be really long to get up there. So longissimus and SCM, sternocleidomastoid, are the two that I care about the most. Does anybody know the other one we remember? It's a neck muscle.
Is it the splenius capitis?
Man, you are on fire, Miss Matas. Yes, that was the harder answer. Mr. Bligent got the low-hanging fruit, but you got the tough one there. And it's the splenius capitis, yes. And later we will learn a fourth one that's a very tiny one. Does somebody know it? I feel like somebody might know it.
I remember where it is. You said it's in the hyoid group, but I don't remember the name.
It's in the suprahyoid group, although most people don't put it in that group, but they should. And it's called the digastric. And it kind of hooks in from here through your hyoid bone and back to here. It's very weird, very strange. Anyway, 4 bones there. But that's not the end of the excitement of the temporal bone. People, the temporal bone. It's amazing. It's amazing because right now you can hear me through a hole in your temporal bone. Your external auditory meatus. Yeah, cool. But it doesn't stop there. For the low, low price of $19.95, there's still cool stuff about the temporal bone. Yeah, still cool stuff. It makes the joint between my mandible and my temporal bone is the temporal mandibular joint, otherwise known as my jaw joint. So it has a lot to do with TMJ. TMJ syndrome, we believe, has a lot to do with neck tension and things like that, pulling on this area and the fascia of that area. Yes. And it doesn't actually even stop there. There is a little teeny bone that you will never feel that's called the styloid process of the temporal bone because it's way inside the head. But it also attaches to a suprahyoid. So there's a lot going on with this guy. Temporal bone. Respect the temporal bone. Okay. This is a beautiful picture of the foramen magnum. It's the bottom of a skull here. What comes out there? Is that just to drain water out of your brain? Because if it builds up in there, slosh around. No. It is your spinal cord. It comes out. It's really thick when it comes out, yeah. And literally. If you cut it off there, you wouldn't feel anything from your head down. You'd have some other problems too, by the way. Okay, we talked about the temporal mandibular joint. I don't think I've ever used this term, but the atlanto-occipital joint. Remember that C1 is also sometimes called the Atlantis, the person that holds up the world. And so it's sometimes called the atlanto-occipital joint. And it's really what allows me to actually kind of rock my head like this. They kind of articulate that way. That's C1 in my occipital region. C1 and C2 allows me to say no, no, no. We haven't gotten to this yet, but we will later. All these bones, like the parietal bones and the occipital bone and the frontal bone, they are held together by sutures. They really, when you were a child, remember, they were soft. You don't really say it like you remember. Do you remember with children that they are soft in their head when they're little babies? You have to be very careful. You can't press on their head. Like you'll press into their brain. It kind of freaks me out. But anyway, but they eventually sew up. Well, even to this day, these are considered immovable joints, but we actually know for a fact they flex just a little bit. So people actually even get tension in these areas. It feels really good to have your sutures like kind of rubbed in there and things like that. All right, I got to ask, Miss Mejia, what was going through your brain there? Very expressive. I'm being nosy.
Well, I don't know. I'm just kind of reacting to what you're saying. Like,
you were feeling it.
Yeah. Like, I don't know. I wouldn't want somebody touching my brain. Like,
no. But now your brain's covered, and so when people have these really incredible scalp massages, don't just think about like scraping across their scalp. Feel, because you can actually feel the sutures, and you can kind of work along them. It's fun. That
kind of grosses me out, so I don't know. No, not like that. Just like you.
I got it. Yeah. Well, when you have it done, it won't. You'll love it. We'll see. That's what I'm saying. Okay.
Good.
What? Who? Yes? It feels good?
Yes, it feels good. When you try it, you will, oh, I love my head.
Yes. Yes, that's true. Yeah. I forgot to tell you, I'm really not on firing on all cylinders today. I forgot to tell you another feature of the temporal bone. That's why I just went back here. The temporal bone comes around and meets with my zygomatic bone, and they make my zygomatic arch, which is my cheekbone. I know you've been admiring them. I have really nice cheekbones. But that is, your zygomatic arch is actually formed by your zygomatic and your temporal bone meeting. And by the way, your masseter muscle runs underneath that for your chewing. So once again, we've got even more jaw tension that can get in that area. Just had to throw that in there since I forgot, and I did forget. Okay, here's the lovely hyoid bone, which I incorrectly labeled as the only floating bone in your body. But it's true that patellas are floating too. And we still don't really have a, but the funny part is, like, I think that's lovely, Miss Mejia, that you pointed that out to me. What's funny is all the books, though, refer to it that way. And I don't know, it took fresh eyes for us to make us think about it differently. Anyway, by the way, the hyoid bone seems to have a lot to do with your ability to speak, swallow, and breathe essentially all at once. So this thing, I know it's not your vocal cords, but it has to control lots. You have to do lots of really fancy stuff with this mouth here. And the hyoid bone is actually attached to muscles inside your mouth, and it attaches to your tongue, and it lets you control these very precise movements that you do inside your mouth. Okay. Suspended by ligaments from the temporal styloid process. Temporal bone, deep inside. I never thought about that. It's shaped like a miniature mandible. It's like you have a little jaw inside your throat. That's kind of creepy too. I gotta stop looking at you. You're throwing me off, Miss Man. Talk about rib cage and sternum. How many true ribs do we have? Anybody remember how many true ribs we have? We got 12 ribs. You're correct, by the way. Anybody remember how many true ribs? True ribs? Maybe? Miss Walker, why? Do you remember how many true ribs we have, or what a true rib is? And it's okay if you don't.
It attaches to something, the actual sternum.
That was actually really good, Miss Walker. That's really true. So true ribs attach directly to the sternum. They have their own cartilage taking them to the sternum. And we have It's 7. You're exactly right. Good job. So her definition is excellent, and this 7th rib has its own cartilage that takes it to the sternum. But if you look at 8, 9, and 10, they cheat, and they feed into 7's cartilage. And so 8, 9, and 10 are called what kind of ribs? Anybody?
False.
False. I'll take it. That's exactly right. And then you've got 2 last ribs. What do we call those?
Floating.
Yeah. Okay, great. That's exactly right. Floating. Cool. And remember, every rib in back attaches to what kind of vertebrae? I don't know if I phrased the question right, but I don't know another way to put it. What type of vertebrae does every single rib attach to in back? That's right. Anybody?
Thoracic.
Mr. Placencia, go for it.
I think somebody said it, but thoracic.
Yeah, and don't forget, guys, there's how many thoracic vertebrae are there?
So, $12.
Yes, 12 thoracic vertebrae because there's 12 ribs on each side. And the point I'm trying to make here is they're called thoracic vertebrae because they're associated with ribs, and your thoracic region is anything front and back associated with ribs. And that's why you have 12 thoracic vertebrae, 12 ribs, and all that stuff. Cool. Thank you. Good stuff. We don't have to get that. We did talk about the areas of the sternum. Like this whole thing is your sternum, but this little top part up here where it kind of bends back is called your manubrium. And down here is your xiphoid process. You can find it on yourself. It's a little bone right where your ribs come together, and it doesn't feel too good. You can actually adjust it a little bit. Like I can get mine to kind of go a little bit left, pop over. I'll show you later, Miss Mejia. You'll like it. It goes click. Yeah. Okay, and that gets us to the vertebra. We already talked about the thoracic vertebrae of 12. What is 5 plus 7? It's a math problem. I know you guys aren't mathematicians, you're massage therapists, but 12. And strangely enough, there are 7 cervical vertebrae and 5 lumbar, and 5 plus 7 makes 12. That's just, there's no reason for that I'm aware of, but it just helps you kind of remember that. Yeah. Cool. Woo. Great. Okay. I love this picture. Do you guys remember when I told you about the ligamentum nuchae? Excuse me. I think when I first heard about ligamentum nuchae, I think about this little rope going from here to here. But the side view shows that it actually fills in all the way to the back of the neck, right? It actually fills in some of your curve there. And it's ligaments like this, by the way, if we had to study ligaments in this class, I'd honestly have to extend the class another 2 or 3 years. Because for every muscle you learn about, there's about 20 associated ligaments. Not attached to that muscle, but helping hold that joint together and all that kind of stuff. There's ligaments everywhere. Everywhere. Ridiculous amounts. Ridiculous amounts. And the ligamentum nuchae is just one example of something that actually attached to your head down to here, helps keep all this together, helps prevent whiplash, and actually fills in all the way to each vertebrae. And that's why we got those really confusing things. Remember when we were studying muscles and we're like, oh, the trapezius attaches to the ligamentum nuchae, and we're like, why don't we just say it attaches to the cervical vertebrae? It kind of does, because ligamentum nuchae is attached to the cervical vertebrae. This is why stuff gets very complicated when we really talk about where it is in the body. Yeah? And you see how there's a ligament actually running all the way down your back, tying all the spinous processes together? Supraspinous ligament. So, and there's other ones, there's transverse ones and everything. So your back is sewn together with all sorts of fascial material. There's more connective tissue in you than there is muscular tissue. There's more ligaments than there is muscles, way more. All right, just about done. We talked about vertebrae at one time in this class, the body of the vertebrae. Don't forget, the vertebral canal there, that's where the spinal cord goes through. That's this hole for the spinal cord that's been coming down from your brain to go through, and then it branches out off the sides and gets nerve plexes, and what we really care about is when it gets pinched here on the side and such. And you all know where the lamina groove is. It's where you try to elbow people's backs now. You actually try to get your elbow between the spinous processes and the transverse processes. You try to get your elbow right in here. Because there's a lot of delicious stuff in here. It is delicious. There are things like rotatories, and multifidi, your spinalis, even your longissimus is kind of right around this area. It's all in there. Yeah, you got to get it. Okay. Nice picture of a disc. Discs, by the way, are between every single vertebrae. They're cartilaginous joints. The outside of the disc is pretty hard. The inside is it's like a jelly donut. So the inside is meant to take shock. The outside is meant to keep the jelly inside. It doesn't always work. Over time, with lots of stress, the jelly starts to bulge out and it hits the nerves. And that's a herniated disc or a blown disc or a slipped disc. They don't really slip, but that's what they mean. It's as though it's slipping. It's sneaking out a little bit of the side. And by the way, for those of you that work on clients that have this problem, and you will, probably one of the most common problems in the world, people can heal from that. The disc won't necessarily go back in, but the massage will relieve them enough of pressure, and over time they'll build up scar tissue in here, and it'll kind of hold the disc back in. So some people with herniated discs heal completely. It takes a while, but they heal completely, and you just kind of keep them out of pain by keeping all the compression away. You try to open up their stuff instead of having it compress. But over time, they'll often build up scar tissue in there, and it'll kind of create a new disc wall for them, and they'll be okay. It's not the end of the world. It feels like the end of the world at the moment, but it's not. Okay. Boom, boom. All sorts of different types of vertebrae. And a beautiful picture of your sacrum. Which, remember, your sacrum started out as multiple vertebrae that fuse together. That's why it looks this way. And those holes there are for nerves to come out from your sacrum. And we massage sacrums in this class, right? Because it's delightful, yeah. And many people, you won't be down this far in your massage, I know, but if you were to go a little bit further, you'll know many people have broken their coccyx, so oftentimes their coccyx is sticking over to one side or the other. That's pretty common. Okay. We're not going to do all that yet. Okay. And that gets us to skeletal muscles. The most, just give me 14 more minutes, I promise. The most important thing to remember about skeletal muscles is that they can only do one thing. And what is that? Contract. They can only contract. I don't mean that they can't get lengthened again, but they don't get lengthened on their own power. They can contract and let go, but they're not pushing stuff back apart. They can contract. And that is the entire understanding of kinesiology. If I understand that something's tied to here and something's tied to here and they contract, I don't really care if this comes over to this or this comes over to this gap closes. And that's what I meant. In space, we don't even know what's happening. We just know they got closer together. And that's what muscles do. They contract. In general, the origin is the place that doesn't move. In general, the origin is close to the midline of my body, and the insertion is out here to the thing that moves. But that isn't always true, and I don't even think, from my point of view, I could care less. In my mind, all I think about is attachments. I don't care if this is the origin and this is the insertion or vice versa. They're attached to both, they're going to move together. That's all I need for kinesiology. And that's not a cop-out. That's just not getting hung up on the term origin. Right? And just give you a really quick example to kind of make that point. My origins for muscles down here attach up here to help me do a pull-up, right? Well, when I'm doing a pull down, I'm pulling the insertion close to my origin. But actually when I'm doing a pull up, I'm actually pulling my origin to my insertion. But it's the same darn muscle. Nothing changes. Nothing changes in that action at all. Cool? Muscles in front generally create what type of action? Muscles in front of your body generally create what type of action?
A flexion.
Flexion, thank you. They're here, they pull stuff in front. Muscles in back generally create what?
Extension.
Extension, yes. Muscles on the outside generally create what?
Abduction.
Abduction. Muscles in the middle, like the ones between my legs.
Adduction.
Adduction. Very good. I'm not saying that's 100% true, but I think you guys see why it's true, right? Cool. We already got all that. Oblique muscles run diagonal, so they often create rotations. They're trying to do two things at once, and that tends to create a rotation. We remember that prime movers are the main muscles that do an action. They're also referred to as the agonists. They cause agony, not because they're hurting you, but they're the ones working. Prime movers are often agonists. They often work in synergy with other prime movers, with other muscles, working together. Antagonists are usually located on the opposite side and they can pull against that, right? So in this case, which muscle is the agonist?
Bicep.
Yes. And in this case, which muscle is the antagonist?
Tricep.
Tricep. Yes. And by the way, everybody, now in this case, which muscle is the agonist?
Tricep.
Yes, thank you. They switch. It's not like we decided biceps are always agonists. No, they switch. It completely depends on their action. We're just talking about actions. And the reason we make a big deal about this in massage therapy is quite often it's not that your client's having a problem with their bicep pulling their arm in. They're having a problem with an antagonist stopping the arm from coming in. Quite often we're having problems with tight muscles stopping actions. This is very, very important in athletics because quite often you have a runner come to you and you don't work on the muscles that's propelling them forward, you work on the muscles that are holding them back. And they get instant performance because every time they were taking a stride, some other tight muscle they were having to fight against their own muscles to take the stride. And if you remove that problem, all of a sudden they seem instantly more powerful, instantly faster. So we're oftentimes trying to stop the opposing muscle from being so tight and stopping an action. We see this a lot in golf, by the way. Golf requires a really full swing to do it right. And if you can get somebody really loosened up just right, their golf swing works so much better. So much so when I was at the Princess, I invented a golfer's massage for them. That they then got like this golf guy I don't remember who he was, I don't watch golf, but some famous golf guy to come and receive it and endorse it and all this kind of stuff. But his argument was he could actually hit further after the massage, which he really could.
So you invented that massage, that technique?
Yeah, and they own it.
What? How did that happen? You should have been owning it.
I worked for the Princess, and they asked me to do something. I said, okay, I'll do it. I didn't know what I was doing, I was just tickled pink it worked. And by the way, if you guys want to know what the massage was, essentially, it was a massage of like rotational stretches with PNF stretching, that kind of stretching that we've talked about, PNF stretching and massaging the tight spots while they're in a stretch. So we've literally been teaching you the massage that we invented. But it was a very simple concept. Boy, did it work well, though. It really increased rotational flexibility. Yes, Ms. Sarno.
Like have a lot of people get like anterior deltoid, like get like a tight.
Oh yeah.
Like a server or something, have everything.
I see anterior deltoid problems in all sorts of different scenarios, but you're absolutely right. You see a lot of anterior deltoid problems in weightlifters for one thing. Bench press really works your chest, but it actually puts a tremendous amount of strain on the anterior deltoid. It's much smaller than the chest. And so a lot of weightlifters tend to overload their chest and the deltoid can't keep up with it. So we see that. We also see people at a desk who work hunched over and the anterior deltoid kind of immediately rotates their arm in. I'm exaggerating here, but so we see tension there from like desk work and things like that. And so yeah, I see it in all sorts of different cases. Yeah, common, super common. I hope that's what you're asking, but yeah, I see it in all sorts of stuff. Remember that muscles, as we get into kinesiology here, the reason I've been asking you guys for 4 months, like, does it cross over this joint? I'm well aware, hold on really quickly. Hold on really quickly, we'll find out here. Here's an arm. I'm well aware, this is the bicep here, that it doesn't look like the bicep really crosses over the joint because what really happens is this little tendon at the end crosses over the joint. But that's what I mean by it crossing over the joint. I mean, it's hooked to a rope that crosses over the joint. And remember, if a muscle doesn't cross over a joint, it can't affect it. If it does cross over a joint, it affects it. That's 100% true 100% of the time. I cannot think of a time that that's not true. So this is why we care so much. And by the way, if a muscle crosses over 2 joints, It affects both of them. Now, you can have other muscles stop that from happening, as we do with the biceps. You can lock your shoulder down so the biceps don't affect it and they only bend your elbow, but it affects it. And it could. If you didn't lock it down here, it would also raise your arm up. So we really, really care about where muscles start and where they go, and more importantly, what joints they cross over along the way. That is kinesiology. Kinesiology is honestly muscles contract and shorten. Whatever joints they cross over, they affect when they contract and shorten. And if they cross over multiple joints, they can affect multiple joints. And we need to know where they start and end so we can figure out what joints they cross over. And then kinesiology gets a little more complicated because it might look at 10 muscles at once working together, but the point is that's it. That's the whole concept. Does that make sense? Questions about that? Kind of okay. At least in general. This is all the stuff we couldn't tell you all at once in the beginning, so we're kind of tying it all back together. Okay. We've already talked about how muscles are named, right? And by the way, they're not named all the same. We found out it depends on who discovered them and how they named them. It's usually some Latin Harry Potterish name that denotes their size or their location or the number of heads they have or their origins or what they do, or a combination of all those. Biceps brachii tells me that I have a two-headed muscle in my brachial region, right? Cool. Okay. I think this is a good place to stop before we really dive into muscles. So I've released your matching. Well, let's start with that. I've released your matching. Everybody feel free to take a 15-minute break and not start your matching right away. We can reconvene, whatever that is, at 5:11. I will be back at 5:11. I'll be here to help you if you have questions, all that good stuff. And this is matching 5, 6, 7, 8 of this chapter.